A very good morning to all of you. We all treat diabetic macular edema because diabetic macular edema has become very, very common. And unlike cataract surgery, where one swipe of the knife can cure the patient for life, diabetic macular edema and all the other medical retinal conditions, including age-related macular degeneration, requires continued, sustained injections. So our chancellor, the need of the hour as per our chancellor would be basically doing cutting edge research. What she says is, if you make more and more hospitals, you can touch a few lakh more lives. But if you do cutting edge research which will make a change, it can touch 1 billion lives or more. So that is the thought process. So that's why I started this 2016 proteomics and molecular medicine study group in our institution. And we all know that in diabetic retinopathy, there are 3 things that will help the patient. Number 1, good, tight metabolic control. Number 2, our work like laser, anti-VEGF, steroids, all these things. And finally, in conditions which worsen, we will do retinal surgery. So there are typically a lot of patients in whom we give multiple anti-VEGF injections because whenever we are posed with a diabetic macular edema, our first thought process would be to give an anti-VEGF. We may vary depending upon what is the frequency of administration, what would be the type of anti-VEGF which is used primarily and secondarily, etc. But we all generally tend to use anti-VEGFs. And many cases respond just like this case. It would reduce an edema. And finally, we may consider some laser to the leaking microaneurysms and stop it. But there are a lot of other patients in whom you can see over the years itself, the macular edema has worsened and it has remained worsened despite injections, over 4 years, the patient had multiple injections and no significant improvement in the hard exudates or the diabetic macular edema. With one shot of Ozurdex here, this patient cleared. You can understand the difference. So there are patients like this who are significantly responding to one particular group of medication versus the other, which we are currently unable to decide. So this is again another patient in whom multiple injections were given. You can see that edema may reduce slightly, but it will come back. So it is again difficulty. So what I did is we wanted to do a molecular analysis, cytokines and VEGF levels of patients who are undergoing diabetic macular edema treatment and find out why some patients are responding so fast and why some patients are not responding so fast. That is the difference which we have to make. All right. So we looked at diabetic macular edema patients and we gave them ranibizumab 1, 2, 3 monthly. That is mandatory for all the 40 patients. And for 4th and 5th injections were non-mandatory, which means that if there was edema or if there was decrease of vision, we would give. If there was no edema, we would not give the 4th and the 5th injection, and the 6th injection was mandatory. And each time when we looked at when we gave the injection, we took a bit of aqueous, about 50 microliters of aqueous, and we stored it, and we looked at an ELISA VEGF, and we found out that there are 3 groups of patients. One group, the 2 groups of patients where the VEGF was slightly lower, less than 500 and less than 1000 were behaving almost similarly in terms of vision as well as CMT. Whereas there was one group of patients with very high VEGF, more than 2000, who were behaving completely differently. Okay? But that was only 10 to 15% of patients. Now, we divided these 40 patients into very good responders on the one hand and very poor responders on the other hand. I did not cut in the center. I wanted the best and the worst so that we could find out the difference between them. Because that is what we essentially want to find out, right? So only if edema reduced by 40% in the first 3 months, or if only 4 injections, the mandatory 4 injections were required, or if macular thickness was normalized within the first 3 months, all these 3 are present, then I would say they are very good responders. All these 3 are absent, then I would say they are very poor responders. And then we looked at cytokines as well as VEGF in these patients. I would just run through these slides and tell you this one. Okay? The red is the non-responder patients, which means that their visual acuity and the edema is not better. And you can see the CMT and the best corrected visual acuity. This is logmar. That's why it's higher. So they are worse in the red worm. Now look at VEGF. VEGF of the red worm is actually lower than the responders because the 4th and the 5th injection were given in these patients, whereas 4th and 5th injections were not given in the other patients. So it is not non-reduction of VEGF which is actually causing them to be non-responders. It is something else. So now our attempt was to find out what it was. And so we did electrophoresis, looked at differentiation in proteins between these, and also look at a cytokine analysis and found out that IL-6, IL-8, IP-10 and MCP-1 were very high in non-responders as compared to responders. And that is published. And these are the cytokines. And then I wanted to correlate the edema, the type of edema and the OCT biomarkers with the cytokine levels. So you can see here, this is a typical, so these are the parameters looked at. IL-6 levels were much higher in spongy edema when ISOS junction was disrupted and drill was there. So these are some of the OCT biomarkers which may help us tell that, this is cytokine predominant diabetic macular edema or a VEGF predominant diabetic macular edema. Now the idea would be to develop a lateral flow kit. Our first prototype is ready, just like a pregnancy kit, which would tell me, whether this patient is a responder or a non-responder. So we have currently two kits, IL-8 and IL-6 kits, in which they are both in the same kit. So we are looking at developing 3 lines developing. So depending upon the line which is coming positive, we will say which cytokine is involved or which VEGF is involved, which will ideally tell us whether to treat this patient with an anti-VEGF primarily or to treat with a steroid which will reduce all the cytokines. Now the biology is open because now we have IL-6, IL-8 inhibitors, MCP inhibitors, so we can go to personalized treatment with conditions like this. Thank you very much.